Welcome to the Challenging Cases sessions. My name is Rohini Manuel. I'm a consultant microbiologist at Public Health England. And along with John Lambon and Tom Chiller, we will be presenting this session. So I'm presenting the first case, which is with Nicola Lau, which is on is that a yeast or mold, challenges in tissue transplantation. So I'm just going to invite my expert panel to sit in the front. There's been some changes because a few people could not make it, but Nicola and Mark have come. Tom, yeah, sorry. So that's John Lambon, and he'll be talking from an infection control perspective. Tom Chiller, who'll be giving the US perspective on the cases. Nicola Lau will be giving the ophthalmology and the eye bank perspective. And Mark Wilkins, who's service director at Moorfields for corneal transplants, will be talking about the management side of things. How do we move the slides? That's a good point. Okay. So the aim of this presentation is to talk about some recent cases at Moorfields, which is the fourth largest corneal transplant center in the world, highlighting the fact that the eye is an immune privileged site. And you could ask the ophthalmologist what that means later. But basically it means that the eye does not mount an immune response, unlike other sites in the body. So it's harder to diagnose an infection. Challenges in the tissue transplantation, which is very different from the challenges you see in organ transplant or in bone marrow transplantation, in that you can have multiple pathogens involved, which makes it harder to detect. You can have the same source for different pathogens, as you'll find out. And also want to talk briefly about the pathology modernization challenges that we are all facing with networking and consolidation, and which Mark will probably highlight during the talk. So I'm going to hand over to Nicola just to talk briefly about the types of corneal transplants, because it really is outside my area of expertise.
Thank you, Dr. Manuel. This is a very quick overview of the types of cornea transplant that we do. Broadly speaking, this partial cornea transplant or full thickness cornea transplants. And we choose the types of transplant depending on the pathology that the patients have. And this is a very simple, simple schematic diagram on the full thickness cornea transplant, which we call penetrating keratoplasty, PK. And then the partial thickness transplant is a deep anterior lamella, and also the endothelial cornea transplant we place inside the eye is endothelial cornea transplant is DSEC, or what we call DMEC. And this is a picture of a preparation of a DMEC cornea transplant, which has now become our one of our gold standard surgery for endothelial, the innermost layer of the cornea pathology. It does take. It is being prepared by hand by the surgeon here, and this is one of my patients. I'm sorry if the projection is not very good. Underwent a partial cornea transplant, and you can see that the sutures in there to hold the transplant in place.
Thank you. Do you want to hold on to that? Mark, do you want to pass this around when different people are asked? Thank you. Okay, so the first case is an 88-year-old gentleman who has type 2 diabetes, and he had a late complication of cataract surgery, which resulted in corneal decompensation, which led to him having a form of endothelial corneal transplant at Moorfields St. George's. So Moorfields has 32 sites in London, the southeast, and the east of England, which is also relevant in this presentation. And he attended on day 54 to Moorfields St. George's for removal of the suture. And so on examination of his eye, this is what they saw when they examined him. Would anyone like to point out the pathologies in the eye? Marla, would you like to try? Since you've got an eye unit in Croydon. Do you want to just come up and just say anything? No? and I'll just point out briefly what it is.
So, absolutely. So this is the hypopium, which is a leukocytic exudate. You see that the eye itself is very congested, very inflamed, quite angry. Cornea is quite cloudy, can hardly see the details of the pupil. And you're quite right, there is a fungal colony right there. And this is a schematic, just to say that this is inside the eye, inside the anterior chamber, the eye.
Okay, thank you. So Mark said to me that actually just say the white blobs in the eye, that means you've got a fungal infection. So that's all become nice sentence now. So we Candida labrata was answered from culture vapors fluid and also separately by PCR, which they sent to micropathology. So how do you think the fungus got there? During suture removal on day 54, exogenously through the corneal transplant, endogenous spread, none of the above, all of the above. Now, unfortunately, this has not gone into the app, so can you just vote by hand? Who says A? Nobody. Exogenous B? That's quite a lot. I suppose you might have guessed it because you looked at the corneal surgeons sitting in the panel. Endogenous spread? That's the most common route. Exactly. Okay, so it was B.
It could have been all of the above, you said.
Pardon?
It could have been any of those sources.
It could have been, but
So the answer would be what it is.
well, in this case, it was C. No, it's not, Sheila. So what would you do now? So we're all, we have a prosthetic knee. What do we say? Take it out. Okay. So who would remove the corneal transplant? The app is your hands, I'm afraid. Not that many. Okay, that's interesting. Mark, did you put your hand up as well? Excellent. Who would do a washout? Nobody. Nobody. One person. Okay. Good, Mark, can you tell?
You make some small incisions and you just put an infusion in and then you let the stuff wash out of another hole, and then you can put something that will aspirate the fluid. You can then take that fluid, and send it to analysis as well. And while you're doing that, you can then put antifungals into the eye at the same time.
Okay, so they didn't remove the corneal transplant, bad people. They did a washout. But there's just no right or wrong answer. So, going back to the prosthetic knee, the eye is slightly different because of the immune privilege site as well, so that's quite important to remember. So, antifungal therapy. What formulations? Oral treatment, fluconazole, intravenous treatment with amphotericin, or phytocytosine, topical treatment, intracameral, which is injection into the anterior chamber. They've just done an anterior chamber washout. So, would you like to vote? Who'd go for oral? Nobody. Mark would. Who'd go for intravenous? Nicola would. Who'd go for topical? You? Who'd go for intracameral? Oh, no, that's quite impressive. I didn't even know what that meant a while ago. So who'd do half of the four above, and who'd do all of the above? Dave, what would you do?
I've done the intracameral treatment and given some IV therapy.
Excellent. And what would that done? Okay. So would anybody do all of the above? One lady would. Excellent. Anybody else? Dr. Shin. That's impressive. Okay. So the reality. Okay, sorry. So, which agent do you use? Do you vote fluconazole, voriconazole, isobuconazole, I saw that hand, prednisolone, amphotericin, flucytosine, ampho, few you said, and flucytosine, okay? Flucytosine?
Yes.
Okay, this is the reality of what happened.
So do you have an MIC of the eyes?
Do I have the MIC of the isolate? I can't remember what it was.
Because they've got quite raised in my CC.
Yeah, so there would have been a raised MIC to fluconazole. But this is what, Mark, do you want to talk through that actually?
Okay, they did what they did, it wasn't my patient, so this happened at St George's where they have access to physicians who can start giving them intravenous therapy. So with the subsequent cases you can see that we didn't use any intravenous therapy because we don't have access to it. What else to say really?
Okay.
I think the other thing is worth saying about some MIC, often you start therapy thinking this looks fungal, this looks wrong, this doesn't look bacterial, but you don't know anything more than that. And often we'll get some sort of identification back quite late. And so you've often gone in and had several rounds of treatment before you get some real proper answers about what you're treating.
So what's the rationale behind this? Why do you give them fluconazole and Vori, for instance, and precisely?
I don't know if you know any of that.
So first of all, when the patient was diagnosed, he was treated as an outpatient. He, on the background of diabetes, he's actually a little bit frail as well. He then had surgery and a local anaesthetic with the washout, so he had 2 washout with the intracameral voriconazole, and then he was subsequently treated with oral fluconazole and penicillin under the guidance of the other of our medical retina team as well. He was
so why was it choice of fluconazole? Because we know that La Rata is not very susceptible, so why not give Vori system?
At the time, fluconazole was given as per our protocol at the time he was responding, but then he got some cardiac problems separately from this. He was admitted as an inpatient under the medical team, and that was when we were able to go and give him the intravenous physitocin because he was then an inpatient and had access to it.
So I think the fluconazole was given when they didn't know what the pathogen was at the start when he was seeing outpatients. And he was discharged home, but it took a while. So Mark, do you want to talk about the delays in getting results?
Yeah, it can be really hard to find out what's going on. So you can, from the picture you saw there, you know that that's odd. It's a big white fluffy ball at the top of the eye. That's, it's as crude as that. That doesn't look bacterial. It just looks wrong. It looks fun. It looks like it's highly likely to be fungal. That may be as much as you've got at the beginning to go on. You can kind of send your anterior chamber aspirate for staining, for culture, but the information is going to come back piecemeal, frequently where our fungal results come back from the West of England reference laboratory, so we can be waiting days, occasionally weeks for an answer. That's what we face anyway. If your labs work differently, great. That's kind of how it works for us. You can get other bits of information. You can do confocal microscopy. You can get literally you can have a very high resolution image of the cornea. You can sometimes find filamentous organisms that will further show you which way to go. But you can be waiting at least a week before you get anything serious back, so you know really what you're dealing with. And by that time, you may have done 2 washouts. You may have done all sorts of things in an attempt to improve the situation.
So I think it's important to mention here that Moorfields does not have their own laboratory, so they send their cultures off to one laboratory, Laboratory A, they send their PCRs off to Laboratory B, St George's is the 3rd laboratory, so that's Laboratory C, and this happens quite a lot. Hence, pathology modernisation challenges, because this is something that we're all going to be facing increasingly as you get centralisation.
But, excuse me, it's not, because of that, shouldn't one use initially empirical something cover a possibility of resistance? So what would it be your second choice? Because we know that could be, this candidate could be flavrata, could be resistant to fluconazole as well. So what is the fluconazole because of penetration your first empirical choice? Because it doesn't cover, like say if we had a blood culture sometime, patient very sick, we would go a little bit more than that until we know what's going on. So I'm just trying to see.
Well, I think, sorry, Mark, do you want to go for it?
I was going to say, most of these cases are so rare, we haven't really evolved a policy for what to do if you've got the first line doesn't work. I mean, for us, the frequency of fungal infection in the graft is really quite low, so yeah, we haven't.
Especially oral, because So can you get away with the glabrata if you have a high? Because it can't be dose dependent. So if you give oral, then again, it's suboptimal, if you know what I mean.
Yeah, well, these are the first, there's more than one case going to be presented here. These are the first, I can't remember the last time I managed a candidate with glabrata infection, so we have to go and then talk to a microbiologist for this sort of advice, so that's why we haven't got a policy. And unfortunately, I think maybe this is going to speak about how we arrange our services. We often start this on our own and then go and find a microbiologist and talk to them if it doesn't get better. And that's a shortfall of how we arrange our services, and that's what we've learned from this whole process.
Okay. But also, I mean, for eyes, they don't have inpatient beds generally. So when the patient was admitted, they were admitted under the infectious disease physicians at George's. Hence, in HIV and AIDS patients, you get, for Cryptococcus, you get amphotericin and 5-FC, and that's why the 5-FC was given. But actually, it was quite interesting because this patient did very well because of the additive synergistic effect of ampho and 5-FC for Candida, which, if you hadn't used the 5-FC intravenously, I think the outcome might have been slightly different. Just.
What's the penetration of different antifungals to anterior and posterior chamber?
There is quite a lot of variability, but both amphotericin and 5-FC get in very well, as does voriconazole. Fluconazole less, but it does get in orally, and that's why it's as given as outpatient first choice. And they use topical as well, because that gets in as well, even though it's... Okay, so this is just the timeline, just to say that from surgery, in June 16, it took 64 days until September 16 before the patient finally presented and Candida glabrata was grown. So it's quite a long incubation period, which is because the eye is, I think, immune privileged as well. So then the next case, we have to move a bit faster now. 73-year-old male, he had graft failure following 2 previous partial thickness corneal transplants, and he underwent a PK, which essentially just means a full thickness transplant, and also had his a repositioning of his intraocular lens. So this is the image of the eye when he presented. Nicola, do you want to just quickly take us through it, please?
Yeah, absolutely. Again, these white fluffy fungal colonies, which is in the interior sort of endothelial, so inside anterior chamber, and also some more satellite colonies. Didn't jet very well, but you can see that there's some more down here. Could also be part of the exudate as well. These lamellar sutures, which is holding this corneal transplant, and here again the eye is extremely very, very angry and very inflamed, and the cornea transparency is lost. It's very, very dangerous and hazy. And the microscope, what we can also see is that the patient also has a lot of inflammatory cells in the aqueous, having to further loss of vision. The patient presented with symptoms of pain and photophilia.
Thank you.
Were these visible to the naked eye, or is it just big
But they're larger now.
Yeah, I imagine the ones at the top.
One's at the top one.
And just to reduce ophthalmology to a really crude level, multiple white fluffy blobs fungus.
Okay, so this is what they found. Would anybody like to take a guess at this? Sheila?
Would you take a guess at that? Is that chromogenic AGAM?
It is.
Yeah, careful with the ones that purple are the glabrata or parapsilosis.
Excellent.
It's quite shiny.
Okay, so the audience saying glabrata and parapsilosis. Let's see. Excellent. Very good,
But it
Mike.
does depend on the chromogenic agent that you're using, so the pigmentation does vary depending on what manufacturer of chromogenic agent that you've got. So the one that we use, and plus you've got glabrata doesn't produce pseudohyphae, they're always unicellular. It's only you only get small budding and there's no hyphae produced.
Okay, thank you for that. So then, surgery. This is what happened. The lens was taken out. A patient had a vitrectomy, and they had 5 washouts for the anterior chamber. Sorry. So this patient had a lot of intravitreal treatment with amphotericin and voriconazole. Also treatment to the anterior chamber, 5 times amphotericin voriconazole again, oral fluconazole and topical amphotericin. So Nicola, do you want to take us through that?
Absolutely. These are just a series of photographs showing the patient's journey, essentially, after each washout. And it actually highlights the sort of situation that we have to deal with. So initially, you can see that from here, that these are the fungal colonies right near the eyes. It's again very, very inflamed and quite angry. And then this is the end of November, and then at the beginning of December, the patients also have had a washout. It cleared up quite a bit with some of these fungal colonies there, but then it recurred pretty quickly, actually. And then you can see that the patient that underwent another further washout got better, and then these fungus then come back, even though physically when we're doing these washouts under a very high microscope, and we actually, like what Mark said, we aspirate and wash them out and actually give them intracameral amphotericin or voriconazole and also into the vitreous cavity. It responds initially, but pretty quickly these would then return. And then you can see that the cornea transplant after each washout picks up a bit better, started to get a bit cloudy again, and then microscopically, under a very high mag on our biomicroscope, split now microscope, you can see that these fungal colony grows back again. And then eventually, after a few washout, the cornea graft is still surviving. You can see that there is we're getting a clearance of fungus.
So I was in theatre on the 13th of January actually, and when they did one of the washouts, it was quite impressive. Okay, so this is the timeline here for this patient, and you can see it took 43 days from the time the graft was done to presenting, and that's how long it took before the patient resolved.
Scheduled for a series of washouts, an injection washouts.
And I mean, the eye didn't look good at all initially, actually, when I was in theatre, and it did make a remarkable improvement.
But happily, just to say that after this series of washouts, the hard work paid off, and he's now off all antifungal treatment, and he has physical, he's got clearance.
Could I ask, did all those washouts go up for culture and, identification of any bacterial or fungus? Do you have results back for that?
I believe so, they were
You've got results back for that?
Sorry?
You got the results and you got the results?
Yeah, we don't have it here, but they did send it off, yeah. Okay, so we've got 2 kind of vibrato guys. What would you do at this stage?
I've learned a lot about corneal transplant. Take the procedure apart completely and look at all transport fluids, the theatre environment. I mean, you've got to go to town. This is.
Well, just after 2
high
cases.
suspicion You've got linked kittens, right?
Just after 2 cases.
Well, we've already heard this is rare. We've got the same organism in 2 cases. I don't think we've got any option. It's sight-threatening complications.
Would anybody else take action at this stage? Pardon?
Were the same blood letters, were the same typing?
Actually, to be honest, we tried to get typing and we didn't succeed. We even tried to get whole genome sequencing actually from the Aberdeen fungal group, but it just didn't succeed in getting the samples processed.
Was it some fractured lenses or whatever it was that had been replaced, or was there a contamination issue with the thing that they were putting in?
It was do you want to answer that, Mark?
So I didn't quite hear you.
Where did the lenses and
So what you were inserting in the eye, were they batches of stuff? Was it the same batches? Was there a
Transplant.
contamination issue?
In terms of the transplant, or you said an intraocular lens, so
I'm sorry, I didn't
Yeah.
know. What did you put in?
the human tissue was from the same source, if that's what you mean. From the same, yeah. You'll see in a minute what I'm being slightly hesitant to tell you. Yeah.
So that's a very good point. So Dave and Sue, well done. That's the key point here. So so you've kind of, go on Tom.
I just have a question for you guys. So with all the wash, so do you try to save the cornea first? In other words, not remove it and do another transplant, correct? So part of your strategy is, can we keep, even though we know it's infected, can we keep it in and we wash it out, and we treat with antifungals, et cetera, and not have to remove it, correct? Is that sort of the, and at what point do you throw in the towel, so to speak, and say, we got to pull this cornea out?
If you could cut it out and you know that you were going to cut it out, you would just cut it out because you can always get another transplant. But if you take that out, you don't know that whether there's fungus in the peripheral rim of the host, so you could take it out and feel temporarily much pleased with yourself, but the stuff will just come in from the periphery. So that's really the concern. So you would ideally like to treat the infection. There's a high chance that graft is not going to survive, but it's better to kill the bud and then come back on a later date when the eye is uninflamed and do a graft. And that's the thing, if you graft in a hot eye, the survival of the new graft is always reduced.
Okay, so, I mean, this is what I would have done. I think some of you have gone the whole hog. Well done. So I would have discussed this with infection control, say, 2 cases, what would you have done? And this is what Moorfields did. Look at the background rates of infection, because, they got 2 in a few months, and it took such a long time between the operation and the presentation that, months have passed. Look at the background rates of infection over the 3 to 5 year period beforehand, see what they were. Discuss with the service director, who's Mark, and ophthalmologist like Nicola, and hold an incident meeting. So, would you hold an incident meeting at this point? Hands up. It's quite a lot of people. That's quite interesting. Okay, that's the vote then. An expert panel, Mark? So, Tom would.
Yeah.
John, would you? John as well, okay.
I guess I've got one question is if, because Moorfields is clearly spread over lots of sites and you use lots of different labs, do you have a single infection control team, or do you rely on an infection control team of all the different sites that you operate on?
We have an infection control team that should look at all our activity on all our sites. We didn't have an, you can talk about this, or do you want to say what happened?
You too.
We didn't have an instant meeting because I didn't know about it. This is also relevant about how you share information, and again, it's what we learn.
Okay.
2 different hospitals, the 2 patients.
Yes,
Correct.
the first case is St George's and the other, by different surgeons, different theatres and different sort of structures.
So it's just one this was an isolated case.
Yes.
Yeah.
Well,
Because thinking now retrospectively, obviously, you said that both the corneal grafts came from the same
Source, yeah.
whether one should have proactively gone and see where the next one
which
went.
we'll go into later.
Okay, so-
Okay. So third case, 77-year-old male who's got this endothelial dystrophy and who underwent an endothelial transplant. And this is Nicola, do you want to talk about it?
Yes, this is actually one of our, when I was working for Mark. And so this was, again, very inflamed eye. The patient presented with symptoms of pain photophobia very briskly and attended A&E and was immediately brought to our attention. You can see here the cornea is very, you can see the clarity of the cornea, you can see the iris details quite well at the top, but at the bottom here it's all very edematous, very cloudy. And you can see 3 very fluffy white balls with white colony, fungal colonies there.
Yeah, thank you. So who'd like to make a diagnosis of this? Pardon? Well done, Sheila, that was quick.
It had more than lots of providers for it with WNS.
Sheila, could you just explain the picture on the right? Do you mind?
Which is the right?
Thank you. Okay, just to Candida albicans, whenever I look at that, if you do a corneal ALA, which is like a deficient rice tree, that's the old ALA, but now you just have corneal, you stress the organisms to produce these chlamydospores. And if you actually look under the microscope, under times 20, they're sort of like refractile, and I always sort of like, they're sort of similar to white cells. When you do a CSF count, you see white cells, you see that refractile illumination. I find the same thing when you look at Candida albicans. So as soon as you see a bubble at the end of a true or pseudohyphae, you know it's Candida albicans. It's one of the strong indicators that it is Candida albicans.
So Sheila, can I just ask you a question? Because there's 2 ophthalmologists here, and they would have thought this was a filamentous fungus, wouldn't you, Mark?
Well,
Yes.
Candida albicans is dimorphic. It produces hyphae and it produces budding cells. So you get both. But it's not, can you see it's a bit bulbous? When you get filamentous, they're quite direct, straight lines.
It's like a learning experience, actually, I think.
Yeah, it's learning how to use the pointer itself.
I know, it's hard.
So when you see, even though like Canada albicans can produce pseudo-hyphae as well as true hyphae, and that's another indicator telling you it's Canada albicans. You can see they're sort of bulbous. When I think of them like little cocktail sausages, when they're pseudo-hyphae, they're like little cocktail sausages with constrictions as it elongates. Here we haven't got any true hyphae at all, I can't see any, but you can get, where you can get direct septate, it's when the hyphae produce little septate, and it's a way of a defence mechanism. So if you get antifungals, it can actually block up those little holes between septate, and so some of the organisms can actually survive where the rest can die. And that's quite true of Eucharalis, that's a really good defence mechanism for Eucharalis. This is just your ordinary sab agar, but if you put it on a chromogenic agar, you get a beautiful deep green pigmentation, depending on the chromogenic agar you use. And we like to tell the difference between these albicans or dubliniensis, and one of the indicators of being dubliniensis is on the chromogenic agar, it's actually sort of like an emerald green, like from Dublin. And if you look at the count, the kaleidospores on your corneal agar, dubliniensis produces something like 50 to 60% more of these refractile kaleidospores than Canada albicans.
Thank you. Okay. So the patient had the graft removed and anterior chamber washout, and they had intracameral amphotericin, fluconazole, amphotericin, and chlorhexidine. And again, there's a long timeline here you can see between the surgery and the presentation. So what are your thoughts now? 2 glabrata, 1 albicans. Come on, lots of microbiologists in the audience. John, what would you think?
It seems less related. And I wonder whether the albicans is more common than the grants. But it would be nice to trace back to see if there's any relationship between these cases. But the fact that different organisms, to my mind, suggests a different source.
Tom, what do you think? From an epidemiological background.
Well, I think, again, we've already heard this is extremely rare, so we're concerned. There's now 3 cases of fungal infection. 2 different species suggest that there's not maybe a single point source, some clonal point source. At least that's what I'm thinking in my mind. But Canada is Canada, and what Canada likes to survive in different environments. So, heavy antibacterial use, and so I still wouldn't be going away from outbreak. I still wouldn't be going away from cluster. I would still be thinking there's a problem, a potential problem. I mean, or could the albican be an outlier and the cluster is the glabrata? So, I mean, my mind would be sort of going like that. But if we thought they were all related, then I would be thinking less of sort of some defined point source where you had a bunch of glabrata growing. I'd be thinking of some other sort of source to the outbreak.
Thank you. Dave?
And I know we're in a mycology meeting, but I'll also be asking the team, have you seen an increase in bacterial infections as well? Is this a theatre environment or processing issue that's also causing an increase in bacterial infections?
Very good. Oh, sorry, Mark, go on.
I was saying, no, at the time we weren't. But it's still at this point, I didn't know about this.
Yeah, okay.
I'm going to say something a bit about how we monitor stuff in a second, actually, because we're not completely kind of clueless about
Okay. So by this stage, Maurizio, sorry.
I noticed something and I thought maybe it's not relevant, but now that you discussed the possible source, I don't know whether you noticed that in the second case, the glabrata colonies almost coincided with where the sutures were. So they kind of initiated where the sutures were. If you go back to the picture, you will see that and I was wondering whether the source could be the sutures or the...
Well, here.
No,
it's the case 3. It has to be case 2.
They're close to it, but I think when you get true suture-associated infection, it'll be like here. If you had, but here, well, it's close to it, but it tends to be really intimately associated with the suture if it's really associated with the suture. If you get, it's quite common in the graft to have a loose suture and an infection, but you'll really see it around the suture. This is, these are close to it, but not really intimately related to it.
drugs we use, like I had experience in the past with staph epi infection, and this was not one, they were not using the one use only, so they had this container for disinfectant or something, and they were always going back to it and topping it up. So sometimes, like these steps, it's important just to do visit and watch what's.
That's true, and that did happen in the end.
Can I just, what state are the grafts in when you get them? How are they kind of packaged for delivery to you?
There's two types, this will become relevant as well. There's a UK source which comes as organ culture, which comes in some medium, that it's been taken out of organ culture and detergents, but they come in pots of fluid basically. And then there's American tissue which we'll talk about, which comes in a slightly different material, different fluid. But yeah, I mean basically it's a pot, it comes in a pot of liquid.
And do you culture the liquid when you dig out the graft, when you use the graft? Do you actually send the liquid for culture or anything?
Not routinely, no.
Well, those standing like to sit
But
in the
sorry, I
front.
should just say that with organ culture transplants, they've been sampling the fluid whilst it's been sitting in the eye bank, so they've been sampling it anyway.
So the UK tissue is cultured, and if you find anything, it's chucked away. Whereas the US tissue, Tom, do you want to talk about the US tissue? What happens? We can talk about later. We'll talk about later. Okay. So, what are your thoughts now? 3 cases, 2 different. Okay. Incident meeting. We've been through that already. Okay. Fine. So, case 4. 64-year-old male had a graft failure. He had a previous full thickness transplant, and that failed. And he then went to have a endothelial transplant, and that was his eye.
So this patient actually had a very rapid presentation. He had extreme pain, and you can see that this eye is just not injected, it's actually scleritis in the eye. His vision was sectionalized, was extremely poor, and you can see that his eyelid, maybe not very well projected here, is very attentive. Main point is here, he had the cornea transplant, both of them. So he had a full thickness transplant from previously, and then an endothelial cornea transplant underneath, which we often do for transplant that's been old and failed. And that is one of the extremely edematous. There's a large white infiltrating inside, and you can see that there is some fluid coming out of the eye. And if I can tell you, is that this eye is perforated, so it has the ulceration and the necrosis is so bad that there is a direct communication of the anterior region. It's leaking fluid from the inside of his eye to outside.
Thank you. Okay. Does anybody know what this is?
It's not penicillin anyway.
This. Okay, Sheila, since you provided the slide, would you like to talk us through it?
Now, does anybody have a guess what it is?
So you know what it is.
Right. Yeah. Both know, both on the same page. So this one here, it's not as pigmented as it would, but this is about 3 to 4 days. If it was about 5 to 6 days, you get a beautiful powder blush. I always think of it like the powder blush that one puts on your cheek. It gets powdery like that, and it actually resembles like powder pack because it's fine, dainty, and that resembles in its microscopy, as you can see here. This is we call it verticillate, which is what penicillin does, but it's not as robust. It's more delicate. It's got more delicate structures, and there's ellipsoidal spores, which are sort of, can you see, tapered at the end. So we all have all this describing of an organism. If it was penicillin, it would be much more, it would be the same structure, and that's why people get confused between penicillin and piperacillin. There's 2 clades of piperacillin and lilicillin. It used to be called Pachyomyces lilicillin, but they decided to change it and give it another big long name so that we have always something exciting to remember. But it is a saprophytic organism. It's soil environment, so we tend to get it quite a lot in nail specimens, which we tend to disregard because it doesn't cause onychomycosis. So coming from a different clinical site, it would hold more significance.
So why is there a different colour one? There's one that's more...
That's the reverse.
Right, okay.
So, the one so with mycology and laboratory, the top of the organism is just as important as the reverse. So you use both sides of the colony to actually identify the organism. And I prefer conventional testing than all this sequencing and, microarrays, all that other stuff.
Thank you very much, Sheila and Sue. Okay, so this patient, so that was an interesting pathogen, different one. This patient had intravitreal amphotericin, oral voriconazole, and topical natamycin. So Mark, again, you're using natamycin rather than amphotericin topically. Could you explain why, please?
Yes. Our protocol is for anything filamentous to have natamycin. So that's really why. So that's filamentous, or that's filamentous disease? Yeah. So just reflecting my poor clinical knowledge. Yeah. So I mean, we have a trust policy. Filamentous, natamycin, yeast, amphotericin, really, and that's based on quite a lot of studies of infections, fungal infections, particularly from India, where they get a lot more of them. And it also reflects what you actually have available, because there are lots of drugs that you guys might recommend that exist as IV or oral formulations, but they don't all exist in drop formulations, and even ones that we do use have to be compounded and made up. So, we don't have a lot of drugs in our armamentarium.
It's also very expensive. Do you want to see how expensive they are?
Natamycin, I don't know. I think voriconazole comes in about £900 a bottle or something like that.
£250 for natamycin per bottle.
Oh, £250 for natamycin in total. I think when you make voriconazole drops, you get 1 bottle of IV prep. You make 3 bottles, and of which they release 1. They hold on. They test one of them, and they keep the other one for surveillance. So it is eye-wateringly expensive, and if you consider these people are going to be on drops for months, it certainly cost becomes really relevant.
Yeah, I was really surprised how expensive the topical and all the different formulations cost. Something you wouldn't really realise in general microbiology. So 4 cases in 2 months. So who'd like to take a vote? A, who'd cry? Okay, that's good. Who'd pull your hair out? Nicola and Mark. Who'd take constructive action? Oh, that's good. And who'd take no action? Nobody. And who'd watch and wait? Okay, so...
Can you just explain why nothing happened?
No, it's okay.
No, we can't. Okay.
John, do you want to say anything about this? What would you do?
No, I guess just reflecting on the 4th case, it had a very different phenotype to the other 3. So much quicker, the eye looked very different, it looked much angrier, it was much more invasive, there was perforation. And I guess that just reflects the difference in the bug, I guess. It's just interesting to know the physiology and how the difference in clinical presentation.
And also, clinically, like what you said, also this patient is slightly different from the other 3 previous gentlemen, in that this patient is slightly younger, 60-something, and he actively travels internationally. And so there was some doubts whether he was able to keep up with his eye drops post-operatively, whether he was able to look after himself, whether he was just travelling so much internationally, whether he picked up on something else. So there was other factors to consider as well.
But none of them are classically immunosuppressed. I mean, the first patient had diabetes, but none of the others has any sort of immunosuppression. Okay, so this is just a question, we've gone through it already. So, to be honest, on a personal level, I might have waited until this stage actually to do something, being very honest, because the first case happened in another hospital, then we had a Gibraltar at City Road, and then the 3rd one was in albicans, and the 4th one was the purpuricillum, and I mean, at 4 cases, I thought, okay, there's something going on here, maybe I'm being honest, that's what I would have done on a personal note. So at this stage, I would have involved senior management, had an incident meeting, probably, and this is what Moorfields did, contact the Royal College of Ophthalmologists and contact colleagues at other corneal transplant centres in the UK and abroad to see if they have seen similar rise in fungal infections and do a literature review. So then the question comes at this stage, you've got 4 cases. So Moorfields in 2016 did 840-something corneal transplants. And they had to stop surgery at this point. So what do you think, would you stop after 4 cases of fungal infections? When you got lots of patients being referred actually from all around the country, all the complicated eyes get referred to Moorfields. So would you have stopped surgery at this stage after 4 cases? Dr. Shen, would you like to answer that?
Well, this sounds like an extraordinary series of cases. This sounds like quite out of the ordinary. and there's a risk of patient safety, and I'm not sure, although these are site-saving interventions, there's no immediate threat to life of the patient, so it might make sense to pause and investigate to reduce the risk to the patients. I mean, that's just a role.
John, what would you have done at this stage?
Same.
Okay.
Yeah.
Tom?
I think it's a big decision to make if you're doing so many. You know, to say stop when you've got 4 different organisms to go where it might be unrelated. But as Jim says, you've got to balance the risk of pausing, which versus the risk of carrying on.
Tom, do you agree with that?
Yeah, I mean, I think that this is the word stop is the challenge for all of these situations, and we deal with a lot of them, and you'll hear about more later. But yeah, I mean, I think that's the big question. So, yeah, I don't know. I mean, obviously I know this scenario, but I definitely would be actively discussing it, debating it, and looking at this cluster and trying to understand relatedness before I push the stop button. But I think both of what these guys have said make total sense to me. At least it is an elective surgery to a certain extent. It's not like we dealt with the fact that we shut down a transplant program because of 3 fungal infections, and not me, someone else shut it down. And that's really a challenging decision to make because you're stopping life-saving surgery. So that was really not taken lightly at all. And I think at least in this case, you have an opportunity to reflect and investigate. So.
Excellent. Okay. So we're at 4 cases. Who would have stopped elective surgery before now? Before the 4th case, at the 2nd case, for example, who would have stopped at that point?
I guess it depends on when you do your investigation, whether you've got a plausible explanation for what's going on. And you know, if you, and we've already heard that they're in different theatres, so you look, you know, if there is a common link that it's going to be something to do with the supply of the graft or things that are remote from the actual hospital where the surgery is occurring, and if you look into that and find that plausible explanation, then you know you can very much focus on that and take steps to prevent it, and perhaps then not need to stop.
Sorry, do you want to?
Just a couple of observations though, really. By now, if you were carrying on, do you need to change the way you consent the patients?
Interesting.
What do the patients think themselves?
Interesting. Mark, do you want to?
Yeah, we are more mindful of that, and we do talk about that more. And I think they accept it. I mean, you explain. I mean, if you take the time to explain it's coming from a living donor, and you can't boil the sample, if you use, you discuss it in those terms, they kind of get that you're doing your best to exclude infection, but you can't completely exclude it. So yeah, I think they in general are okay about it. But yeah, how much risk would you say now at this stage?
Do you have to say, oh look, by the way, over the last year we went for unexplained?
Yeah, and I think we become clear what happens next is how we're able to do what we did.
Yeah. Okay. So at this point, the trust involved external stakeholders. They contacted the Human Tissue Authority, Public Health England, and the Clinical Commissioning Group. Because it's a big decision to make. So common features then. We've touched on this already. All 4 cases received donor tissue from a US eye bank. Tom, do you want to say anything at this point? And all donor tissue was stored in Optisol GS. Do you want to just explain the process briefly, Tom?
Yeah, and probably Mark knows it better than I, but there are 2 sources that you were getting your recordings from, one in the UK and one in the US. The major difference, really, is that, at least in my mind, the major difference is one includes an antifungal in the solution and one doesn't. You can imagine which one doesn't based on what you're doing. So the US, the Optisol solution, they do not include an antifungal. There are antibacterials. There's not an antifungal. I think they felt that there was no need to put it in. This has been like this for 15, 20 years. I don't know, how long has the UK been including an antifungal in their solution? Oh, yeah. For like, I think so, yeah. For like years, right? Yeah. So, yeah, and so that's the major difference between these 2.
But also in the UK, they culture.
Yeah.
the tissue, and if they find anything, they will discard the sample, and that's critical as well, which doesn't happen in the States.
Yeah, the other thing is in America, when the eyes are harvested, there's no swab taken of the harvest site. I don't know whether they found that wasn't useful, but certainly it's not done. So.
I think the reason why that is having spoken to some ophthalmologists or some eye banks in America, is that they had previously taken a swab in situ when they harvested donor, and then they would invariably grow something that never actually correlates with the tissue, with the actual tissues. And so they found that it was just a bit random, and it wouldn't correlate with the actual swab they had taken from the tissue, and therefore they have abandoned it, I think, after.
Can you also explain, because I remember you guys were telling me about this when I was here, explain why the U.S. tissue was sort of more desirable in certain situations than the U.K. tissue?
We just didn't have enough supply.
Okay.
I mean, we were just doing so many grafts, we couldn't meet the supply from NHSBT, so we had to go outside. And we are unusual as an organisation to have paid, which is a premium to go and get US tissue just so we could maintain our clinical work.
But wasn't there also a timing issue? You were telling me you have to hold the UK tissue for a certain period of time?
Oh, yes, sorry, yes. There's also that as well.
Yeah.
So the US tissue, they can transplant right away, basically, whereas the UK, they're culturing it for several weeks and they're holding it, right?
Yes.
Yeah, so Tom came over to Moorfields last year, actually, in February, and to meet them because of all of this that was going on.
So the UK tissue is quarantined for infection reasons?
Correct.
Yeah.
Yes,
Correct.
And all samples taken from the donor, tissue, and also from the fluid, also the dextract, which deswells the cornea, and it's a quarantine period of 14 days. So if any of these are actually grows, the tissue is then discarded.
And what's the discount rate?
Not that many, actually.
I don't know that.
I think I saw about maybe 8 or 9 that were discarded in 2016 from UK tissue, and that's 47% of the grafts that are done.
8 or 9?
Yeah, not just fungus, bacterial as well.
Okay.
So like mostly coagulating staph or what's the other skin one? Propionibacterium, and that was the main ones.
It is not from a sterile site, the corneal graft. Yeah. So
No.
we are not going to ever get a sterile
What our
cornea.
guarantees is that when they eat in the both methods, the cold, the hypothermic storage and the warm culture methods, when the eye is actually being retrieved by technicians, they create a sterile site, and they do the techniques aseptically in situ, so they will always wash the site, the eye, with body nardine. They will follow a protocol, they will use sterile instruments, and they will translate into a sterile environment, and I'll go into a bit more detail.
So we need to rush, we're running out of time. So different pathogens, times 3 pathogens, different hospital sites we talked about. The preparation of donor tissue is different. Some of the eye is prepared in the theatre by the surgeons, and some are done at the eye bank at Moorfields. Do you want to talk about that briefly, Mark? Actually, the preparation of donor tissue is different.
Yes.
Why are some done by surgeons and why are some done in the eye bank?
See, the partial thickness transplants, some of them, the first case, the DSEC, we've now trained our technicians to prepare that in the eye bank. The DMEC, another type of partial thickness transplant, we've not yet trained our technicians to do that. So you essentially get the graft, you open it and you manipulate it in theatre and prepare it and peel it, and then load it into an injector and then inject it into the eye. In other sense, particularly in the United States, that would be done at the eye bank as well. But it exposes the graft to a prolonged period of contact with theatre, operating theatre air.
And also you have different operating theatres. You have 8 operating theatres, don't you, Mark?
8 in the main site,
Yeah.
and then 1 down at St George's, yes.
And in the theatres at the main site, there's 4 on this side and 4 on that side, and as you'll find out that all the cases came from one side of the corridor, and you wonder whether there's something wrong with the ventilation on that side of the corridor. So then different surgeons, each operation at 2 surgeons, different batches of donor storage media, we looked into that, and different surgical instruments. And just the timeline briefly.
And we went even through more detail, like drops, the post-op drops, we went through the batches of just everything that anyone had ever met.
Yeah, and the antibiotics as well. Okay, so 8-year-old male, again, he had anterior dystrophy, underwent cataract surgery combined with corneal transplant. Nicola, do you want to just take us through this quickly?
Very characteristic, multiple white fluffy infiltrates, very injected out in the dentist cornea.
Thank you. So this isn't yet, this is just, it was just the mind boggles. So this time you had Candida glabrata and albicans by PCR of aqueous fluid from micropathology. John, what do you have to say about that?
So again, it points to the idea more of a point source time the cases together, but again, not. I think that we're all leading towards the donor fluid.
Dave, what do you think?
Yeah, as weight to the previous concern.
Maurizio, what do you think?
Yeah, I agree with Jonathan. Both are kind of going in the same direction of the two first cases.
But it would be nice to do whole genome sequencing. I don't quite know how variable how the chances of if you had a whole genome in your
We spoke to Neil Gall about that. You were there last year, weren't you, Nicola? And he said it wasn't feasible to do it, and it wouldn't really give us what we were looking for. So we kind of
I think
abandoned
we're
that.
still learning about, I mean, as you'll see, I mean, as you probably all know, Candida auris whole genome is incredibly powerful. But then you can go to another species and try whole genome, and it's absolutely all over the board, and you can't interpret it. I think we're still learning about glabrata. We're actually sequencing all of our resistant glabratas now because we're seeing clusters of resistant glabratas in certain hospitals, and we're starting to wonder about nosocomial transmission as well as simply. So so I think the story's still out on whole genome. Maybe we'll be able to interpret it. The problem is, just like with anything, if you don't have sort of a library to back it up and compare it to, you don't really know how to interpret how many SNPs differences and things like that.
Okay, so just quickly through then, these are the drugs the patient was on, and this is the timeline. Again, it takes many, many months before presentation, and the number of interventions that were done are quite remarkable. And case 6, the only female actually in the group, an 84-year-old lady, again who had Fuchs and who underwent the endothelial transplant. And that's I. Nicola?
Again, this patient, it's worth noting that this patient was completely asymptomatic and returned to see me at day PCR, so week 5 of post-op, and she had noticed an improvement in her vision. And somebody in the audience asked me, can you see this in the naked eye? The first thing I noticed about her was this white dot in her pupil. And my heart sank. And she was very nice, and she was chatting, and I sat her down, and I immediately said, let me have a quick look, and I saw this white colony again, and you can see that either face, there's another white colony right there, and there's some very scattered infection. She didn't have a red eye. It was nice and white, and her cornea was clear. And because she had inflammation inside the eye, she was asymptomatic.
So this one was Candida albicans. So,
when you asked us what to do after the 4 cases, and we kind of agreed to stop the elective surgery, I thought that they also... you thought what? They carry on.
No, but Maurizio, remember I said the timeline is so long. So actually, all the surgery occurred between June and September, and patients were presenting right up to December.
This patient presented
So,
on the 1st of December.
They were all in the system by the time we worked out what was going on.
So that's the problem, because it took such a long time. And again, because I think it took longer because the eyes doesn't mount an inflammatory response very quickly. So again, removal of graft, anterior chamber washer, that's kind of the standard thing. And that's the treatment. And that's the timeline. Again, quite a long timeline. You can see it went up to May 2017 from September. Yeah. So then, another thing here was the mate corneas. What's mate corneas? Anyone want to guess? Dave, you look like you might know what it is.
I presume from the same donor.
Excellent. Yeah, it is. So case 5 went to micropathology, and we had both albicans and glabrata, and case 6 only went for culture in a different laboratory, and we had Candida albicans. So is that unusual? Sue, would you like to talk to that one?
PCR is very, very sensitive, and really if you just do a standard culture plate, you need to be quite experienced to pick out all the colonies.
Exactly, and I think that's what happened here. That we only picked up the albicans and not the glabrata.
Glabrata would have been there, and they would have seen it.
Pardon?
Glabrata would have been in culture, and perhaps it would have been picked up.
It would or wouldn't have been?
It wouldn't have been picked up.
Yeah, I think that was the case. John, what we...
Just a question about, presumably when you say PCR, presumably the cornea was sent, or the sample was sent for 18S. I guess the question is how good is 18S at handling mixtures? So in other words, in the land, you want to do 16S if you've got anything more than a single species, it's really difficult to tease apart, but presumably you can raise nets.
With it, so we went to micropathology and I spoke to them when we had this, just when we went back retrospectively, and they actually go on to do a further species specific. So they did. So after the 18th was positive, they went back and did albicans and glabrata. So I think they're very good actually. I think micropath.
So Rohini, you know you said cases, did they do PCR on that one?
On which one?
Candid albicans by culture. Did you do PCR on cases?
No.
No. So because like you said, it could have been there. Candid glabrata could be there in culture. If you just do SAB, you're going to miss it.
See, the problem with all of these is it took so long to get results back, and it's outsourced to a private laboratory where it went for culture, and they chucked the samples out very quickly. So by the time we rang to ask whether they could forward it on to micropathology for PCR, the sample was no longer available.
Because you could have resolved that if you did it, because if you got the DNA, it's going to be there.
Yeah. So Mark, do you want to talk about the delay maybe and how, what measures have been put in place to try and resolve this for future?
In recognising what's going on, yeah. So it's worth pointing out that our main business is cataract surgery, and we have quite a well-developed system for picking up post-operative infection, which used to happen about 1 in 1,300, now 1 in 5,000. When you get a bacterial endophthalmitis, which presents acutely, you stick needles in the front and the back of the eye, send the fluid off, and then stick some antibiotics in the vitreous. We set up a system where every time you use those packs, it triggers a message that goes to the infection control team, so they're completely on it. We've worked out the statistics to work out whether you're getting a slight statistical blip or if you're getting a true uptick in infection, so that was all really worked out, and I think people thought, well, that was just going on for all sorts of infections. The reality is, when these cases you've seen, most of them were not managed in a similar sort of way. They were taken into the operating theatre where it wasn't done, the taps and the washouts were done in a different way, and the antibiotics were called for a different way, and so the infection control were not getting an immediate feedback about what was going on. Plus we've got the different hospital sites as well. So now we have a system where every time I get any of these, infection control is now informed about what was going on.
Okay, thank you. I'm going to hand over now to Nicola Lausch just to finish briefly about what Moorfields did.
Thank you, Rohini. So just a quick, just to tell you what we do. We're at Moorfields. We're one of the largest eye specialist hospital in the developed world. We have 32 NHS sites, and we see over 730,000 patients contacts per year. And in terms of cornea transplant, we do 800 to 900 per year, and half of which are endothelial keratoplasty. As the technology and the techniques develop, less and less we see will do full thickness cornea transplants. Endothelial cornea transplants has merits. Faster recovery time can be carried out more quicker, and it is a less invasive for the patients. Given the low organ donation rates in the UK, and having such high demands and long waiting lists, and as Mark has mentioned, we source about half our cornea material from a single eye bank in the USA, which is one of the largest eye banks in the world. And we discussed the 6 cases which happened in the space of 3 months, and later on when we discovered this cluster, we found out that they were all sourced from the eye bank in the US, and none of the UK tissues were involved. The rate of infection was 0.71%, which is significantly higher than our preceding 3 years has been less than 0.1%. Interestingly, there have been no other reported cases of any infection from fungus in the US or Europe using tissues from this American eye bank. This is just an overview of the timeline, what happened. So one of your a member of the audience had basically mentioned that why did we still carried on, but actually by the time we discovered what was going on, all these patients had already gone through, and you can see that the presentation times and the average onset was 48 days post-op, which is a long time afterwards. So what we also did was we initiated a hospital-wide investigation involving asking help from the Public Health England and also involving the CDC. We also carried out a retrospective review and recall of 200 patients who were at risk during that period. And we also invited patients back in doing extra clinics, knowing that patient 6 is completely asymptomatic. We invited identify a group of patients who might be at risk and invited them. We also set up a helpline as well. Our medical director wrote a letter of duty of candor to all the patients affected, and in addition to that, also write letters to patients of these 200 patients to notify them of an unusually increased rate of infections and to tell them to call this helpline or come into our emergency access with a 24-hour A&E on site if they have any problems. And we couldn't identify any more cases through this investigation retrospective look-back exercise. This is one of the largest clustered that was reported in the literature. In terms of findings, but the patients were all treated in the combination of intraocular, systemic and topical antifungals and all required surgical intervention. The public health investigation did not identify any links with poor practice or infection prevention control. We felt that possibly the donor to host contamination is a causative factor. And as mentioned, none of the patients who received UK material were affected. So this is a summary of what happened to these 6 patients afterwards. I'm happy. So patient 1, the one who didn't remove the cornea transplant, actually had stopped all his treatments, including topical antifungal, and the graft is clear, is functioning, and he's doing well. Second patient had a multiple washout and injections. Again, the graft stayed in situ, and the graft is functioning, good vision. The patient who underwent removal of cornea transplant actually had successful redo cornea transplant 4 months later and 9 months later, respectively, with very good vision. And the patient who perforated 2 months post-op with the periphysium underwent a redo cornea transplant in another centre and had not known to have any recurrence.
I was just going to say, you asked about removal of transplant.
Yes.
We pulled out the partial thickness ones because you still have the rest of the cornea there, so the eye is intact. So you pull out the partial ones, that's a foreign object, that is a contaminant, but the eye will remain intact. When you've got a full thickness transplant, you don't want to pull that out for the reasons I explained.
Thank you.
And all those redos were with UK tissue?
No.
Two of them
you don't
were.
really get much choice, so they come in for a redo and you're sitting down with them and you're going, yeah, Mrs. Means, you had an infection, we're going to redo you and blah, 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 and look at the part, and you get the theatre and you're like, oh.
What was the duration of the antifungal course?
For which patients? For the redos, well, the redos that we did was so what they did was they had 3 months of antifungal treatment, including systemic and topical, and chlorhexidine and amphotericin and oral fluconazole, and they responded very well. Then after 1 month, we stopped the oral fluconazole. Then at month 2, we stopped the chlorhexidine. Month 3, we stopped the amphotericin. Then they had 1 month of no treatment at all. And when we are certain that there is no problems at all by examining the patient and taking a series of photographs of them and having them under very close observation, we then went ahead and did the cornea transplants. That was successful. No. They were fine. They had clearance.
So, did this result in a change of practice in the US company to add antifungals to the corneas, or is...
Tom? I'll talk about it. That's a very interesting point. It's a very good point. What we did was we had a trust-wide hospital investigation, and incident panel was involved, and we also did a serious incident investigation, and we suspended all cornea transplants from the US. So we did not use the material from the US eye bank, but carried on with the UK material. This series of adverse events were reported to the US eye bank, who then reported it to FDA, and also were involved with the CDCC.
Not in a hurry. I was going to ask Tom about that. You wanted to talk about that, the obligation to report in the United States to the victim, the obligation to report in the UK.
Yeah. I mean, I think that I don't know if you're going to cover it, but you know, I think what's interesting is that when we got involved, we hadn't been aware of issues with, fungal infections in cornea. Honestly, no one has put that on our radar. But then when we look back at the Eye Bank Association of America, and we actually looked at their data, because they collect data, and it's self-reporting, but they collect data on post-operative infection. It turns out that bacterial, which we thought was probably the most common cause, had dramatically gone down, and fungal was on its way out. And we had never even seen that. We hadn't seen that before. So it's really the UK experience that pointed out to us, and subsequently now we've been working in this area for quite some time. And there's a lot of problems there. It's a sort of under the radar issue, but there's actually some problems that I hope they're starting to address.
So these are the teams that we involved: Public Health England, Rohini and Martina Cummings leading the team, external experts, microbiologists from various hospitals and BARTs. Some of you in the audience here is also involved. Dr. Chillers there was involved as well. And we also informed the Ocular Tissue Advisory Group and NHS Blood and Transplant, and also Bristol Eye Bank as well. We seek their expert help. FDA was involved, CDC with Tom, and it was crucial that we informed the Royal College of Ophthalmologists, and an alert was generated to all members of the Royal College to inform them of an unusually high infection, and also just to cascade the message so that we also make people aware. And all the cornea surgeons in the UK were also informed as well, but no further cases were identified. So going back to what Tom had mentioned, is that this is a report in 2016 from the Eye Bank Association of America. In America, they do over 40,000 cornea transplants a year, maybe a bit more, like 60, going into sort of 50,000 a year, so a significantly higher number than we do. And they export a lot of tissues as well. It's one of the very few countries that have a surplus of donor material that they can export. Just to point out here, this is the red bars here are the partial cornea transplants, and as I mentioned earlier, as the technology evolve and this surgery is less invasive to the patient and offer much faster recovery time, this popularity is taken off over the last few years, replacing and overtaking full thickness cornea transplant penetrating keratoplasty. But you can see that the endophthalmitis rate here has actually increased quite a lot over the last few years, particularly in endothelial cornea transplant. The incidence of endophthalmitis, bacterial and fungal, is about 2.8 per 10,000 cornea transplants. And 61% of them are partial thickness cornea transplant involving endothelial cornea transplant. And the most common pathogen is Candida. And however, this incidence rate is from Candida. It was previously 0.014%, is now jumping up to about 0.023% over the last 10 years, with the taking off, increasing popularity of endothelial cornea transplants. So it goes back to what Tom said. This is going to be an increasing problem. The main difference between us and in Europe, in the UK, and the US is that in Europe it's a lot more costly and a lot more labour intensive. In the UK, someone who passed away to sign organ donor card, the technician goes out and retrieves the whole eye, and that's hypothermically kept, taken back to the lab with one of our technicians here, and all preparation and harvest of the cornea scleral disc, which looks like this. All the dissection is done under hood and gown and in a sterile condition. and that is then stored in the organ culture. Dextran and tissue are all subjected to culture, and all culture in a quarantine of 14 days. And the media that we use contains antifungal as well as broad spectrum antibiotics. And so they will not get released unless they pass the quarantine. Whereas in the US, it's a direct in situ dissection from the donor in a sterile field, wherever they can be, ITU, in the mortuary, wherever they harvest the cornea, and then it's directly transferred into this chamber, this plastic chamber in here, and all the testing and everything else, colorimetric testing is all done, and the pH testing is all done externally on the eye. And that organ and the storage material is stored hydrothermically at 4 degrees and is called Optisol. GS is gentamicin and streptomycin and contains no antifungal. And as mentioned before, there's no swab taken, and that's a big difference between the two. In 2003, there was an annual report of our European Eye Bank Association showing the mean incidence of endophthalmitis, both bacterial and fungal, after full-thickness cornea transplant. Remember, in 2003, most of the cornea transplants done with the PK, is that there is significantly lower incidence of endophthalmitis with this method in the Europe with warm organ culture, which is the predominant method that we use in Europe. So we discussed where the infection can come from. Well, it could be contamination from a donor. This large French eye bank study in 2012 shows that a lot of a donor does come with contamination, up to 19.1%, and most of these are Candida. Could it be from the eye bank, from our eye bank at Moorfields, or could it be from the US eye bank? But no other people had reported a problem. What about contamination in theatres? Certainly, we also had things that we can do a bit better at in theatres, but they were not detrimental and direct causative factor to cause the cluster. And as Mark mentioned, when we go and prepare this partial cornea transplant, it's being prepared by the surgeon, and it's exposure to the theatre environment. And one of the theories postulating is that when we prepare this tissue, the tissue is being warmed up from 4 degrees to room temperature, and that enhances the antibacterial properties, and it allows the fungus to grow, first of all, and also with the increased in antibacterial activities, it kills the bacteria and allows the fungus to flourish in a non-competitive environment. One of the things that we have taken steps to do is to minimize graft exposure time in theatres, continue to ensure good theatre practice. We also put in place a enhanced surveillance for 6 months, and we couldn't find further cases. Another thing that we could certainly look into is the role of corneal rim culture, so sending the residual tissue after the cornea transplant for culture, because evidence has shown that if there's a positive culture, then the increases the risk of fungal endophthalmitis by 247 times. And if there is a positive culture, then the prophylactic treatment given to the recipient actually reduces the manifestation of an infection by 7-fold. So Tom can probably talk about, if you wouldn't mind talking about how the CDC is getting involved, working with the Eye Bank Association of America in terms of petitioning for the addition of amphotericin in the Optisol.
Yes, I think because of this, we went back and started putting some pressure on the EBAA, this particular eye bank, and others, just to talk about this particular situation and point out this rise in infections. Granted, it's thankfully still incredibly rare, but it was clear it's doubled or tripled, and it's all fungal for the most part. And so now I believe there are at least 3 pilots going on where they're putting antifungals in. So what's happening is the company itself was harder to get, it was harder not to crack. I think it's Bausch & Lomb.
Bausch & Lomb.
So we tried to talk to them, they talked to us initially, and then they freaked out when the government started calling. So they sort of clammed up. They sent us to their lawyers probably. But the eye banks are much more interested. So, and so there are 4 or 5 eye banks, I think, piloting adding info when they harvest.
Yes.
Well, number 2, we also put out a small business innovative research grant which now we have, I think, 4 applicants. We're reviewing those applications where they can get like $200,000, $300,000 to actually study this. And so we're sort of hoping, and we have 4 good applicants, so we're sort of hoping people will actually, so I think because of this unfortunate circumstance, I think there may be some good coming out of it, and that there may be some change. I think people have the realization that there's a problem.
Certainly when we spoke to the USI, this USI bank recently, they're actively looking into it. We know that.
Why are they just looking into rather than at the antifungal?
It's still, you know, it's hard to change a process that's been going on for decades. It's still thankfully very rare, so you're still talking about very few cases. I think people still debate whether it was really the cornea, or and so, you know, there's always holes to be poked. If we had hundreds of cases, I think it would be a no-brainer, but we're talking about 6 years more. I mean, it's hard to convince them. I think I'm pretty convinced. You guys sound like you're fairly convinced. It's more challenging when you're convincing them.
Yeah, and also when the amphotericin is toxic to the endothelium, so you've got to work out what is a low enough concentration to keep the graft healthy but prevent fungal infection. And that still is being worked out, I believe.
Tom, is there anybody looking at the manner in which the donor succumbs and an association with fungal infection, with Candida?
When we talk to them about that, and I think you guys probably know better than I do, I mean, these things are, you know, people die in an ICU, they're harvested in lots of different environments. These patients, if they've been in the ICU, they're on a broad spectrum antibiotic. I mean, they're probably many of them are probably colonized with fungus on their skin.
But if you have a circumstance where somebody is, if they have a heart attack, they heal over, their donor circulation stops. But if they're in a process where the integrity of the gut barrier is becoming more and more compromised as they're succumbing, and the circulation is continuing, the opportunity for translocation from a gut, especially one where you might have a candidal bloom due to broad-spectrum antibiotic exposure, presents itself. And it would seem something interesting for your EIS service well, perhaps not the EIS, but somebody who's
my gut feeling is that all these corneas harvested out of ICUs.
Or in mortuary. There have been, I think, two papers I looked into it, and the patients that have had septicemia or had, you know, serious infection on board or prolonged stay in ICU is known to have a more preponderance to having infection in their cornea donor, but that's looking at bacteria. I think there's an older study looking. Just to let you know that this is the last slide. So patient 2 there, having gone for multiple aggressive treatment and intracameral amphotericin, had actually got cornea transplant, survived. And Mark can probably talk about this. And we now advocate very aggressive surgical intervention right at the start of diagnosis. And this is one of our patients that underwent a cornea transplant earlier. On the day of diagnosis, we took him to theatre and we took out his cornea transplant, and he underwent washout as well. Mark, do you want to have anything to add on that?
I mean, just the 2 partial thickness grafts that I managed, by taking them out, the graft out promptly, washing them out, letting it all settle, and then come back and doing another graft is very, very well, actually.
So, cascading lessons learned, then this series of adverse events were presented at the Trust Governance meeting and also Infection Controls meeting. It was also presented at the EU Competent Authority meetings in Brussels in November last year. We've also taken to multiple educational platforms in the UK, Europe and the US, so just to make awareness of this. And just wanted to thank Dr. Manuel for giving us the opportunity here, the expert panel, so we can cascade the message on. Thank you.
I just want to say, actually, I've been involved in a lot of external reviews, both public and England, but Moorfields have been really, really open and honest about what went wrong. And they've even, they talk about usually Canada, they sent the external investigation report that public health England wrote to every single patient, which I was surprised. They had 54 key findings, 45 recommendations, And they sent the whole report, and, and that really amazed me, because working in a hospital, I know, that's not what trusts generally tend to do. And so I was really, really impressed with their openness and honesty. Thank you.
I was struck when dealing with people, if you told them what was going on, they were really fine about it. I mean, they weren't thrilled, but, but they were, if they sensed you were being open and honest, they were absolutely fine about, and went with you. And that was a real learning point for me, actually.